Good afternoon, everybody. Let me invite you to go ahead and take your seats. That was an exciting last panel. I know discussion feels like it should continue, and it will, but we're going to actually continue with one of the themes that came up in the last panel, and that is the drug crisis that we're facing today in terms of fentanyl. But my name is Jonathan Simon. I'm a member of the Berkeley Law faculty and very delighted to be a participant in today's conference. Since I have a lot of DAs in the room, I want to plead guilty to something, but mainly to being a very minimalist moderator, despite the fact that we have the vaguest title of, in fact, they only gave us one word. Every other panel got at least 2 words. We're just drugs. And you might have thought we were just going to party up here, but I think it's going to be a substantive conversation.
The title would be appropriate.
It would be. So the other way I'm going to be quite minimalist here is, unlike my colleague Andrea Roth, I'm not going to give super generous introductions to our panelists. There's this really neat thing called the internet. And if you actually click on the links for this program, you'll go right to their websites. And let me stipulate that these are super impressive people who have spent careers working in this space, and trying to summarize their CVs would take a great deal of the rest of our time, which I don't want to do.
Tell them we keep peak lies about them.
What's that?
We keep peak lies about them.
Well, I will. So let me just say, we're going to go down the line. We're going to sort of split the 2 teams here. And since I'm modestly on the left, I would say we're going to start with the right, and then go to the left, and then the right, and then on the left. So you're going to hear from Paul Larkin, and then Leo Beletsky, and then Dr. Bertha Madras, and finally, but last but not least, Ethan Nadelmann. Before I get them started, I'm going to give each of them about 10 to 15 minutes to share their thoughts on sort of what the most urgent and important issues for our consideration are, and then give each of them a chance to respond to what they've heard from others. And then I may have a couple of questions, but I'm going to strive hard to make sure that we have time for some audience participation in this round. We are nominally supposed to end this at 3:45, but I take it we can go to 4, but we'll see. If we can get back on schedule, I will do that. Let me just say that as I was thinking about this panel, it really struck me that in the decades now that I've been at least observing drug policy and criminal justice policy related to drugs, I can't think of a time that's in some ways more confusing, right? So if you look at the sweep of the last 4 decades, right, from after a brief period of sort of drug law reform and some decriminalization in the 70s, basically for the last couple decades of the 20th century, whether you call it the war on drugs or you have a more nuanced account of what that was, law enforcement was by and large our primary response across the board to the whole variety of so-called street drugs that almost all were considered felonies, certainly to sell, in some states even possession. Then roughly, and some, disagree with me if you like on the history, because I'm not an expert on this, from about the turn of the century, we seem to swing in a different direction, toward more of a harm reduction, toward more of a medical response, perhaps, to drugs. We certainly have seen a lot of reform of drug policy, both at the sentencing level and at the DA level. And now, and it's a very confusing moment, there are signals of a kind of return to a more prohibitionist approach. We've seen laws recently enhancing sentences for fentanyl. In San Francisco, just yesterday, the mayor, in giving her State of the City address, pointed out that she had doubled the number of arrests of drug dealers in San Francisco. So while nobody necessarily is calling for a drug war, there are certainly signals that we're heading back into that direction. The other, I think, historically interesting thing to think about is fentanyl. When I was a student here in the 80s, crack was considered the most damaging drug in America. And we can debate now how accurate our perception was that it was somehow a spectacularly dangerous and destructive drug. But it's hard to doubt that fentanyl's in a whole different league. I mean, 2 of the things that I've been most interested in my career in terms of social bad events are automobile accidents, something that spiked early in this 20th century and has stayed high, and murders, homicides, which you heard about in the first panel. And to sit back and think that more people are dying of overdoses from fentanyl and related drugs every year than the total number of car accident victims and the total number of homicide victims is really chilling, given how powerful and important those trends have been. So without further ado, I'm going to return to my minimalist moderator role of keeping time, and we're going to kick things off with Paul.
Professor, thank you very much. And thank you to the people who have arranged this conference, and to all of you who take the time out of your day to sit here and listen to see if you can learn something that'll help make your life better and perhaps even the lives of others. You have a lot of competing demands on your time. The fact that you are here is a nice way to us of saying that you think there's at least a decent chance that what we have to say will help you, and therefore possibly help you help others. So thank you to all of you. There are, as Professor Simon said, a great many different drugs that are not only topical, but are very, very troublesome. Fentanyl is the obvious one, but fentanyl is keeping company with others. Heroin hasn't disappeared, although it has gone down, in part because the Mexican cartels are using more fentanyl to sell in the U.S. than they are perhaps old-fashioned heroin, in part because, believe it or not, Afghanistan has tried to cut down on the amount of opium that's being grown, and other reasons like that. But what is the problem of fentanyl is that it's an entirely synthetic drug, which leads to the question of what other synthetic drugs are there that are out there that are going to be problems. It's the subject of novel psychoactive substances. For example, as big a problem as fentanyl is, there's another drug that might be just around the corner. It's starting to show up, called nitazene. You're going to see various instances of nitazene out there, in part because it's more powerful than fentanyl, in part because we're spending a great deal of time trying to track and hunt down fentanyl and the like. So those are subjects that could take each up to an entire conference. And if you are at all interested in drug policy, you will probably, if you don't know a great deal already, will probably educate yourselves on them. But I'm going to talk about a slightly different subject, although it has a great deal of affinity with the whole question of novel psychoactive substances, and that's psychedelics. Why? Well, this is Berkeley, and you can't have a conference on drug policy without talking about psychedelics. And so as the result, I decided not to leave that big vacuum unfilled, and I'm going to do that myself. But also for other reasons, too. One is that it shows the cyclical nature of some of the drug policy issues that have come across the spectrum of both public service officials and the private parties as well as academics. Because there has been a rise and fall, and now we're in the process of a potential resurrection of an interest in psychedelics. But it's also because it does involve rather novel issues, not just of law, not just of policy, but also science, as well as the question of who gets to decide each of those issues. Part of that problem results from the fact that the principal law in the United States regulating pharmaceuticals or drugs is not the 1970 Controlled Substances Act, but is the Federal Food, Drug, and Cosmetic Act of 1938, a law that Congress passed at a time when it was not clear that Congress had the authority to do what it was doing, but there certainly was a great interest in doing it. Why was it not clear it had the authority? The Supreme Court had not yet firmly committed itself to a rather copious understanding of what the Congress's Commerce Clause power was under Article 1. So as a result, what do you have? You have a split in authority over this whole subject. The federal government, in the form of the Food and Drug Administration, gets to regulate drugs and pharmaceuticals. The states, in the form of state medical and licensing boards, as well as juries in tort cases, get the authority to decide what is and is not a proper practice of medicine. And what we have to do today is try to decide how those two fit together in a subject like psychedelics, where it may well be that there's a legitimate use for them, but only if they're administered under certain proper medical circumstances, and yet it may well be that Congress doesn't have the authority to order that. Well, we'll see more about that, and you will probably hear about that, if not from me, from others as well. So let me give you a little bit of the history. Okay? Psychedelics have a very long-term history. There are places in the world, such as in Brazil and in parts of the lower 48 states, where they were used for a very long period of time, but only, I should say, in rather limited circumstances. Why? Because they were treated as a sacrament, if you will, in various religions, and were used only under those circumstances. And there were strong, if not compelling, societal and cultural forces that kept them confined in that way. In the 1950s, medicine started taking a look at them. Why? It's two reasons in principle, I think. One was hallucinations gave rise to the question, that is, psychedelic elicited hallucinations gave rise to the question of whether the substances could allow for them to study psychosis as it manifested in its unfortunate victims. And then secondly, they also thought originally that it might have some usefulness in treating victims. But that was in the 50s and the 60s, at least until the mid-60s. And now when you turn to the mid-60s, the term psychedelic has a very different meaning. It is likely to elicit memories, and in some people flashbacks, of what we saw in the 1960s in popular culture. Lucy in the Sky with Diamonds. Yeah, nobody knows what that song was about, okay? How about almost anything the Grateful Dead wrote and sang in the early part of its career, okay? Break On to the Other Side by the Doors. White Rabbit by Jefferson Airplane, okay? How about Easy Rider? How about Yellow Submarine? I could go on, I could go on. There are a lot of very topical names, such as Aldous Huxley, Timothy Leary, and the like. But you know what? They had a rise and then also saw a fall. Now, a lot of people attribute the fall entirely to the adoption in 1970 of the Federal Controlled Substances Act. And that is not entirely true. It's a part, but it's not entirely true. Early in the 60s, we saw the thalidomide problem in Europe. And there was a congressman who had spent the prior 4 years trying to develop some sort of FDA regulation. When that broke upon the scene, he decided to modify the 1938 Act to make sure that not only would drugs be available for national distribution if they were safe, they also had to be effective, because that was a way of making sure that they only did what they were supposed to do and nothing else. So what you had then was a very long period where the research into psychedelics fell into desuetude. It started coming back, however, in this century, in part because we have various disorders, such as what is called MDD, major depressive disorder, which is an extreme version of depression, as well as PTSD, post-traumatic stress disorder, as well as, interestingly enough, addiction, that scientists and physicians thought might be subject, under proper circumstances, to treatment with psychedelics. So they started performing research into this subject. And what we have now is a resurgence of research interest in a variety of very respected institutions. Queen's College in Canada, King's College in London, Stanford. I know it may be an apostasy to think Stanford has any value in anything in this building, but, you know, as I like to say, TFB, which means too bad. Okay, Stanford, Berkeley, yes. Texas, Michigan, NYU, and Johns Hopkins all have their own programs looking into the potential beneficial effects of psychedelics. So we are starting to see them come back up. And why? Because, as I said, there was originally two reasons people thought they might be helpful. Those two probably aren't the primary reasons anymore, but there are several others. Okay? One, they're thinking it may be helpful in treating people who suffer from refractory mental disorders, like MDD, like PTSD. Why? If any of you have ever been in New York City, and I know you have, you know what the subway system is like. You can get on one subway and just spend your entire day on that, or you can make switches. One of the problems that people who suffer from PTSD and MDD have is they get stuck on the same subway line throughout that whole period. And there is hope that the use of drugs like psychedelics can allow them to break out of that and cross over to a different system. For the same reason, it is also thought possibly to help people who are suffering from addiction. Addiction is a disease, not just physiological, although trust me, it has that too, but of psychological nature. And what it does is it keeps you, for example, thinking only about your next drug, and thinking only about how you can avoid the horrors of withdrawal, and doing that by getting the next drug. It thinks you only about avoiding the horrors of your life, which is why you started perhaps on drugs to begin with. And what it does is it can possibly break you out of those tracks, get you the ability to realize there are other ways to connect, and allow you to realize the difference between positive and negative lifestyles. So that is a hope. Thirdly, it is also thought that maybe it'll be helpful to people who are about to cross the river Styx. there are a large number of people who suffer from the terrible thought of either what's going to happen to them on the far side, or that on the far side there won't be anything to happen to anybody. And there is thought that maybe this will help some people make that passage without the suffering that can happen to people at the end of life. And then, of course, there's the last reason, which is it is thought that maybe it can enhance creativity or just general mood, and that, if it's possible and does not harm others, ought not to be reduced to zero. Those are the 4 reasons why people are arguing in favor of not only continued research into psychedelics, but perhaps use of them. Oregon, for example, has made possession of small amounts of these substances no longer a crime under state law, but basically that's probably not going to have the same effect that we saw in the 1980s and 90s when the states started decriminalizing cannabis, because there was no popular upsurge of support for decriminalizing LSD and the like, at least not yet. But that is a possibility. Australia has already legalized the use of psilocybin and MDMA under licensed treatment for these sorts of purposes. And the FDA has before it right now an application to legalize the use of MDMA, which is methylene dioxymethamphetamine, for those of you who had chemistry backgrounds. Actually, it's 3,4 methylene dioxymethamphetamine, but who wants to be a stickler for detail? The FDA will have to decide, which if I have time, I'll say a little bit more about later. But there are some very important, very legitimate, and therefore very worthy of consideration counter concerns that people have about automatically jumping on the psychedelic bandwagon. One, the studies that have been conducted, although much better over the last 20 years, although much better than the ones that were conducted from the 50s onward, do not really have effective double-blind studies where neither the patients nor the physicians administering the studies know who has the drug and who doesn't. Let's face it, somebody gives you an antibiotic, an antiviral, an antifungal, you're not going to have the same sort of psychological reaction that you would if somebody gives you psilocybin. And what that does is it tends perhaps to bias the results, and sometimes even bias the people administering the test. So we have to decide whether, to what extent, if any, or if not conclusively, that absence matters. Secondly, we don't have long-term studies into the effects of the long-term use of psychedelics. Yes, there are plenty of people out there that saw the dead during the 60s and 70s, and we could go to them, okay, and ask, you know, how do you feel, okay? But they haven't been using it every week. They haven't been using it every month. They haven't been using it every year. They probably used it a large number of times in a very finite period. But we don't know what the long-term effects are going to be. For example, some psychedelics run the risk of cardiovascular damage because it leads to a thickening of the valves in the heart. And that, over the long term, can be a problem. So we don't have that yet. We have to decide whether we should go forward right now by legalizing it without knowing that. Thirdly, and this relates to a problem I mentioned earlier, the people who are promoting the use of psychedelics these days are not doing it just simply to make the United States a place where everybody, as Timothy Leary said, tune in, turn on, drop out. No, they're saying that it's valuable in conjunction with psychotherapy. Therein lies a word that has many different uses. Why? Because there is no one uniform way of conducting psychotherapy. And even if there were, it's not clear the federal government can require that only one particular form of psychotherapy be used. Remember what I said a few minutes ago? The federal government regulates the drugs. The states regulate the practice of medicine. Insofar as psychedelics are a matter of drugs, the FDA has the authority. If not, it's in the state's hands. But if they can only be distributed when they're being conjoined with legitimate psychotherapy, then you have the problem of whether the FDA can limit the distribution unless it is proved that they will not be distributed in the same way that medical cannabis was, which we know oftentimes, as was said in a famous San Francisco Chronicle article, that anyone could get if you had $40 in 40 minutes. That's simple. This is a far more dangerous drug, and yet the same technical problem arises. So, what do? We have the problem of deciding whether to legitimize them and mainstream them. We also have the problem of deciding who gets to make that call. Is it the Food and Drug Administration or is it the states? And finally, whoever we think is best capable of doing that, we have the additional problem of deciding to what extent we have to protect that decision or can't protect that decision from the poisoning and corrupting influence of politics. Because what we have seen, at least since I was, knee-high to a grasshopper, as the phrase used, is that politics has encroached more and more on science. Okay? 20 years ago, 30 years ago, no one would have thought that the CDC had the authority to intervene in landlord-tenant relationships. No one would have thought that OSHA had the authority to mandate inoculations, particularly since the word inoculation or vaccination or anything similar doesn't show up in the OSHA Act. It's been politics that has corrupted science. Now, maybe there was always some little influence, but it's not as great as it has been today. And that is troubling. In an earlier life, I represented the Food and Drug Administration, and I can tell you I found no more noble, good-hearted, hard-working, virtuous people that I ever defended in court. But the people I work with were not the person at the top who gets appointed. And whether it's by a Republican or a Democrat, a conservative or a liberal, politics plays an influence in making that choice. And I am troubled by that fact, regardless of how the science comes out. That being the case, I want to thank Professor Simon, and I thank my panelists. And now they can all go on and say, who cares about psychedelics? But I'm proud to be on a panel with such an illustrious crew.
Thank you so much, Paul. And we're going to hear next from Leo.
Thanks. I'm going to stand up just because it's late in the day, and I've been told that when I sit, I tend to drone on, so I'll try to be a little bit more exciting. Is that okay?
Perfect. Is that mic on? Can you guys hear him in the back?
Yeah. Okay. Well, thank you so much to everyone who has stuck with us through this pretty exciting day, and we're nearing the reception, so I'll try to be brief. So my name is Leo Beletsky. I'm a professor of law and health sciences at Northeastern, where I also run the Action Lab. But before that, and I'm sorry that D.A. Ho has left because I was going to try to one-up him. He said that he learned English after moving here as a refugee from Bugs Bunny. I learned English after moving here as a refugee from the A-Team, which actually also holds lessons for the American justice system, because to those of you who are fans of the A-Team, you might recall that they were unjustly convicted and were trying to fight injustice with makeshift vehicles of all kinds. So I had a bunch of remarks prepared, but I actually wanted to follow up on something that was discussed in the last panel that dovetails with some of the research that we do at our lab, looking at this intersection of drug policy and criminal justice policy, specifically looking at drug-induced homicide prosecutions as a way to address the overdose crisis. So, to those of you who may not know, these prosecutions are situations where someone distributes drugs to another person, and when that person dies of an accidental overdose, and I want to stress it's an accidental overdose, there's no intent, then the person who originally distributed the drugs is held liable under a variety of different statutes, including special drug-induced homicide statutes, but they can be prosecuted under different kinds of criminal negligence statutes as well. And this has been sweeping the country under the banner of overdose prevention, or response to the overdose crisis, and holding people responsible for the overdoses that have swept many communities. To illustrate my points, I wanted to bring up an anecdote. There's been a lot of kind of grappling with data versus anecdote, and so I wanted to use an anecdote to illustrate the points that I wanted to make. My colleague Morgan Godwin is a person who had been addicted to opioids, and as a young person had a dealer, Justin, who she used to buy heroin from. This was in Portland, Oregon. And so Morgan and Justin both used heroin together. Justin was her dealer, and so they had this kind of friendly relationship, but also a business relationship sometimes. So one day, Morgan gets a text from Justin saying, "I'm all out of my supply. Do you have any extra?" Again, Justin is her dealer, but they used together, so this was not kind of a unusual situation. So she writes back and she says, yes, I have a gram, an extra gram. So they meet up. She gives Justin the gram of heroin, and they go their separate ways. Justin subsequently uses that gram of heroin and dies, right? Because that heroin had, unbeknownst to Morgan, and Justin, had some fentanyl mixed in, which was unusual during that time. Now it's pretty much the case that most heroin has fentanyl mixed in. In fact, it's mostly fentanyl as a rule. So the next day, Morgan gets another text from Justin saying, "Do you have any more?" And she writes back that she doesn't really have any more, but if he wants to use with her, he's welcome at her house. Next thing she knows, there is a Oregon, I think it was the local police at that time, that burst through her door. She's watching TV, rifles out. She gets arrested for selling heroin to Justin, who is her drug dealer. It's her misfortune that the specific Oregon law enforcement agency that arrested her also was part of a federal task force. And by some weird reason, her case gets bumped up to the feds, who charge her with drug delivery resulting in death. Under federal law, holds a 20-year mandatory minimum sentence. So here she is, 19 years old, having sold a gram of heroin with her dealer, and she's facing 20 years in federal prison. She, through a variety of pleading out and the ability of her public defender to strike deals, also the fact that she's white, she ends up doing almost five years time in federal prison for this crime. She then gets out and becomes a criminal justice advocate and a researcher. And one of the things that she's found that I think is interesting and operative here in our discussion is that when she did a costing analysis of the prosecution and incarceration that she faced for this crime, it was over $1.2 million that the federal government, that yours and my money, was spent on her prosecution and her incarceration. Her friend Justin, who had been her drug dealer, had cycled through the criminal legal system something like 12 times he was incarcerated. At no time did Justin receive monetary or any kind of benefits or supports to help him address his addiction and other problems that he was facing. The federal government and the state government was not willing to invest in Justin until he was dead. And at that point, there was no limit to how much they were willing to spend. To place a 19-year-old person who had been buying drugs from this person who had died behind bars. In addition, and I wanted to kind of stress this because there's been a lot of conversation about victims and victims' rights, to highlight not just the fact that the distinction between victim and perpetrator here is completely blurred, because in fact Justin had been selling drugs to her, and it just so happened that he died in this very specific instance, but that Justin's mom, who knew Morgan, and Morgan had been over to their house, they were friends, Justin's mom had appeared at the sentencing saying, "I do not want this to happen. This was an accident." Justin had assumed the risk of what he was doing. He knew the risk. He was doing this himself. He was selling drugs himself. This was an accident, right? Despite this very vocal advocacy by Justin's mom, the prosecutors went ahead with it and put Morgan behind bars, completely changing the course of her life. And when we talk about this distinction between victims and perpetrators, and don't victims' rights matter? Don't victims' voices matter? Yes, they absolutely do. But our criminal legal system cherry picks whose voices it chooses to lift up. Because lots of folks advocate for the exact opposite kind of intervention in many of these cases. Many communities advocate for completely the opposite interventions. But it's very convenient to cherry pick specific and coach folks to have specific viewpoints. There's lots of folks out there whose kids have died or whose loved ones have died of an overdose who don't know what the answer is, who don't know where to turn. And when our elected officials, DAs and others, talk to them, they have the choice to advocate for different kinds of responses. Responses that focus on reducing people's harm, including education, providing folks with harm reduction supplies, naloxone, fentanyl test strips, reducing people's demand for heroin and fentanyl and other drugs. So we have a choice of deploying different kinds of interventions, and yet when people who are animated by grief come to those elected officials, we choose to prioritize interventions that focus on retribution and something that looks decisive and plays well on TV, but in fact does not prevent future overdoses. And just to highlight, overdoses in Oregon have continued to spiral since that time that Morgan was incarcerated. And of course, that one prosecution wouldn't change the course of that trajectory, but that's the hypothesis that a lot of times prosecutors talk about. They say this will send a message. This will deter people from dealing drugs in our communities. This will have an overdose prevention effect. And we've looked at those data and we found that no, in fact, drug-induced homicide prosecutions do not have that effect. And in many communities where drug-induced homicide prosecutions have increased, the overdose crisis has actually worsened in line with other communities as well. So again, this wasn't what I was going to talk about, but I think that this kind of fits in with a lot of what we had been discussing. And I think that, in kind of just conclusion, I would say that misinformation has a huge impact on the course of drug policy. It always has. The panics about opium use among Asian immigrants here in San Francisco had triggered some of the first prohibitions against opium. The connection between Mexican immigrants and cannabis, which is why we still call it marijuana. The role of xenophobia and racism has always shaped our drug policies, which is why our drug policies are so out of step with science. And so it's really important that we acknowledge that and that we develop ways to fight misinformation, monitor misinformation, and address it. We really haven't done a very good job with that, and this is something that I think is important not just in drug policy, but in broader public health policy as well. But in this space, especially given that legacy, it's critical, and I think that we're going to continue to experience crisis, the crisis that we're seeing in overdoses and problematic substance use until we can figure out how to address misinformation on a more systemic level. Thank you.
Thank you, Leo. And we'll hear next from Dr. Madras. Would you like to stand up there? I guess you have
I've got slides.
slides.
Do you want this?
I think that's a good idea.
Bertha, do you want this mic?
Oh,
I'm
isn't
sure that one is working.
this is working? Yes? Perfect. Thank you. Let's start the clock until I've got this.
Could we?
I've got it here. Yeah, it's right there. And do we have it on full screen?
Slides?
Great.
Could I get some technical guidance here on how to get it up on the screen? I used to teach in this classroom, but it's been too long.
Should come up automatically. I'll select source. Dear me.
I'm going to step away because I can't see.
That's okay. Patience, patience.
We've got plenty of time. It's not coming off of you.
Please don't.
Take your time.
So while we're trying to get through this glitch, I'd just like to begin. It's right, it's here. I'd just like to thank the Heritage Foundation, the Berkeley School of Law, Paul Larkin, an ally of mine, and a number of others for inviting us to this presentation. One of the beauties of this is that it's so rare that I speak to in a panel in which people can disagree vehemently with each other. And so we're going to have probably some fireworks this afternoon, but I hope that there are enough fire hydrants around to turn this off. Our nation is facing one of our most severe drug crises in our history. My point of view can be characterized to an adherence to traditional values and caution. I've been called in the past a pearl-clutching fossil, and quite frankly, I'm very proud of that designation, because it was developed during an era when there was a clear consensus that the costs of drug use outweighed its benefits. And my presentation is designed to try to develop that argument. So we have a terrible crisis, which there's my pearl-clutching photograph that was taken approximately 100 years ago. This is Kensington and Philadelphia. We can see the costs of homelessness combined with substance use, the costs of fentanyl combined with xylazine, which gives rise to what I call zombie-like postures and emotions, and the costs of the fentanyl-xylazine combination with regard to skin lesions and discarded needles and so on. What is the drug crisis? It's the worst in our history. It is contrary to science in terms of the strategies that have been used. It got us these strategies which have done a great deal to cast doubt on the science. We hear science, science constantly. From Leo, we hear it from other people that we have to adhere to the science, but there's so many advocates for drugs that try to deny the evidence. And what I'm going to try to do today is present some of the evidence in a fashion that will seem like getting a drink out of a fire hydrant. A lot of contra common sense has also prevailed in this. And let's look at some solutions. So what we know is that from 1900 on, the U.S. has seen a very dramatic decline in preventable accidental deaths in terms of poisons, in terms of fires, in terms of falls, in terms of drownings. The only one that hasn't happened is drug deaths. And what we find is that there is an increasing convergence of people with alcohol use disorder, which was always our #1 problem, along with tobacco and now with cannabis use disorder. What we have to recognize is that the U.S. leads the world in terms of new psychoactive substances in youth, marijuana use disorder, opioid disorder, and drug overdose deaths. We lead the world with new psychoactive substances. These are some of the data. We lead the world with cannabis use disorder. We lead the world in prevalence of opioid use disorder. And we certainly lead the world in terms of opioid overdose deaths compared to, for example, the European Union, which has far, far lower prevalence. We're also seeing a very large uptick in the number of young people who are dying from fentanyl overdoses. So how did we get here? What are the lessons that we can learn from this? And why are we such an outlier? So let's take very quickly a few lessons learned from the opioid crisis, from marijuana. We won't have time to get into ketamine, but we may be able to look at hallucinogens for a moment. This was a 1980 5-sentence letter to our esteemed New England Journal of Medicine, which claimed that addiction was rare in patients treated with narcotics. It was published by a physician and his assistant, and it was the evidence used by many and a few main pharmaceutical companies to promote opioids in our country. What happened was a letter to the editor of the New England Journal of Medicine usually gets about 10 references, 10 citations. In this case, it got over 600 citations. The dark blue bars means that they were affirmative citations. They agreed with the conclusions that narcotics do not give rise to addiction. And of course, I gave that 5-sentence letter to Harvard Medical School students their first year, and I asked them to look at that 5-sentence letter and find the fatal flaws in the science, and they were able to identify them within 1 minute. By a show of hands, everybody put up their hands and said, "That's ridiculous." Advocates reigned and skeptics were ignored, and that's what we're seeing now again and again reiterated in our society with regard to other forms of drug policy and drug policy changes. This was very low-quality science, and then we had vast amounts of money spent to promote opioids with abuse potential. We had the tragedy of needless pain. We had patients, patient groups, pain societies, medical societies thrown money by the pharmaceutical industry. Then the VA system adopted pain as a 5th vital sign, and then came JCAHO, or Joint Commission for Accreditation of Healthcare Organizations. Our dear open society said that patients in pain are casualties of the war on drugs. And very soon the pressures on physicians became impossible to resist because of a whole series of regulatory and pressure points, and they began prescribing in inordinate amounts, and very soon this country was awash in prescription opioids. In fact, we were prescribing 5 times more opioids on average than most other countries that are the highest prescribers, 31 other countries. Along came fentanyl. People claim, well, it's because we curtailed opioids, but in fact, fentanyl, the curtailment of opioids came after fentanyl appeared on the scene. Fentanyl appeared in 2013. The CDC guidelines came in 2016. And anybody who knows anything about economics will realize that the profits from fentanyl were so vast and so much in excess of the profits from heroin. On a single kilogram cost of investment, you made $80,000 on heroin. You can make over $1.5 million on 1 kilogram of fentanyl. And so we have over 1 million people have died in this country in the past 20 years due to the pressures from various stakeholders, including the pharmaceutical industry, profiteers, politicians, and hired social engineers. They've employed ingenious and disingenuous methods to try to convince the public that, in fact, most drugs are harmless. We should destigmatize their use, and we should just get on with the business of trying to clean up the mess after it happens. With marijuana, long before it became a political, social, financial, and social engineering issue in our country, this is in the this is a report that came from India, the India Hemp Report. The cause of people who were suffering from psychosis in a Bengal insane asylum, marijuana was by far the #1 cause. It was way ahead of alcohol, it was way ahead of opioids. And yet, without the politics, the truth came out, and it's been denied over and over again by our social engineers. More youth are using marijuana daily. The perception of risk has declined dramatically for youth, especially for marijuana, but it was clearly an outlier. And yet adolescents are at much greater risk of developing marijuana use disorder than adults. Within 4 years of steady use, about 20% show the symptoms, and that compares with half that amount amongst adults. There's cannabis withdrawal signs amongst very heavy users. I won't get into all of this. And also the DSM-5 criteria for cannabis use disorder have been vetted over and over again by cognoscenti, who are psychiatrists, who are epidemiologists. Yet there is denial that cannabis is addictive amongst people who are trying to promote it. Adolescent use in marijuana gives rise to multi-organ system changes that can be detrimental to their health. It can give rise to brain changes that have been repeated over and over again, to addiction, to deficits in cognition, to amotivation, to psychotic symptoms, and to functional health problems, even amongst kids who are not addicted. There are dose response. In other words, if you compare kids who never use with kids who use non-addictively and kids who have a cannabis use disorder, you can see changes in major depressive episodes, in suicidal ideation, in cognitive difficulties, in truancy, low GPAs in school, in violence, arrests, and fighting, and so on. And more people with marijuana use disorder, more young people have it now than alcohol use disorder. They also are, it's also associated with a high rate of school dropouts. It's associated with suspected suicides. And there is very growing and solid evidence with the adolescent brain cognitive development study, which is a longitudinal study on effects on adolescents' functional effects if they've been exposed to marijuana in utero. There's also a growing problem with poisonings amongst children who've been exposed at home. And now we fast forward to the more older population, adults 50 and older. There is a dose-response effect with regard to distorted thinking, perception, dizziness, and lightheadedness. And yet we continue to increase the potency of marijuana. We can go into great depth on it, but that potency has a correlation with the number of people who have converted, have a psychotic disorder, have converted to schizophrenia. The more you use, the more frequently you use, the more potent you use, the greater the propensity. And high-potency marijuana products are risky from a number of points of view, and yet there is complete pushback on trying to regulate them. It is estimated from a vast study that was done in Denmark, over 1 million people, combined with our National Institute on Drug Abuse recently, that said about 25 to 30% of cannabis use disorder may be contributing to schizophrenia. And the more the risks, I can go on and on with biological plausibility. There's just not time. We can discuss causality versus association using a 6-factor analysis. So legal marijuana began as a medicine for compassionate use, orchestrated by hired social engineers. We now have more products, we have more use, we have more associated psychosis, and increasing evidence for violence, traffic accidents, and so on. So there's a large chasm between evidence and beliefs, and that evidence has been denied in many, many ways. Another federal agency says marijuana is hazardous for a number of reasons. That's our own CDC. And yet we have a number of states, with Illinois being the poster child for science fiction in terms of the medical conditions that it's been approved of. 10 years ago, I was in Sacramento in the Eastern District, in the Eastern Federal Court in California, where descheduling of marijuana was an issue in a large trial in which 7 expert witnesses for the defense who proposed descheduling. I was the only expert witness for the Department of Justice, and in this case, science prevailed. And the judge ruled that this is not the court, the time, and marijuana stays in Schedule 1, and yet now we have the FDA in what I consider a complete political decision, deciding that marijuana should be rescheduled to 3, not on the basis of any of their rigid criteria, but on the basis of what's happening in the states. With psychedelics, we have, as Paul Larkin so eloquently described, a large public health burden on chronic brain disorders with inadequate or unmet treatment needs. And yet people have generational forgetting again. We forgot about the fact that opioids were a massive plague in our country. In the 1820s, we even in the New England Journal of Medicine had evidence for overdoses. We have evidence for addiction amongst women primarily, amongst soldiers who were treated liberally with morphine during and after the Civil War. We have books written by patients who were abused by psychiatrists with regard to LSD, and the research was abandoned because of these terrible stories, these anecdotes, as well as scientific studies. We had publications on how it could be hazardous, and yet we're now in a state again of scientific denial and generational forgetting. The science versus the reality, how solid is the science? I could spend an hour going through all the papers on hallucinogens, psychedelics, whether or not we can scale the protocols with fidelity, and what are the reality of unintended consequences. I don't think we've learned anything from marijuana. The lessons we've learned so far in our nation in our outlying nation is that you ignore history on drugs, you rely on generational forgetting. Medical public education is inadequate, so is scientific illiteracy. You can fool a lot of people with talking points. The medical community is unable to resist public and private pressure. Vast sums of money are spent to promote these drugs. There's an unenforceable distinction between medical and recreational. There are ballot initiatives, which is not the way to approve medicines. The benefits are exaggerated, the risks are minimized. There's a new wave of unregulated high-potency drugs, and so on and so forth. All these strategies have been used with opioids, with marijuana. They're now being used for hallucinogens. And what is the response? The response from the federal government is to reschedule marijuana when the scientific evidence is dicey at best. And I can get into that in great detail. It's to destigmatize drug use, not just destigmatize people with substance use disorders, and to enable use and to normalize use. So this is a billboard that we've all seen. No overdose, do fentanyl with friends. Talk about normalizing use. These are the failed drug policies of the West Coast. A focus to reduce overdoses, that's the focus. It's not prevention, it's not intervention, it's not treatment, it's let's reduce overdoses and try to throw some money as a token for treatment. Drug use and addiction is not viewed by some as, personal autonomy is valued more. And what are some of the common sense solutions? You take a look at the entire picture and you see where you can insert yourself in supply and prevention and risk factors. Amongst some of the most prominent risk factors is parental influence on substance use. Children living in homes with mothers or fathers who use marijuana or opioids or alcohol or tobacco are much more likely to do so. And even 18 to 30-year-old offspring living at home are more likely. So you recruit parents because parents are a major determinant. They can be absentee, they can cause childhood trauma, neglect, they don't have boundaries, they live in dangerous neighborhoods, the family uses drugs. Asian populations are much less likely to use drugs because the culture denies the benefits over the risks. And so if parents speak very strongly against drugs in Asian populations, you can see a tremendous influence on their children. Unfortunately, we don't have this. And so the perceived need for treatment is terrible. It's less than 10%, and it's closer to 5% amongst youth. So we've got to start to figure out a way how to get people into treatment. And I'm just going to just finish by saying, above all, Oregon has reversed. We have Trojan horses that have used. I say with absolute certainty that I have never subscribed to having a war on drugs. I say that the brain is the repository of our humanity. Drugs promote tremendous changes in people's brains, in their behavior, in their bodies. These changes can be terribly detrimental, or they can leave the body and the brain without a trace. But for those who have not recovered, it can be a very difficult journey and sometimes a lifelong journey. So the brain is the repository of our humanity, and this is a defense of our brains. Thank you.
Thank you, Bertha. And last but not least, we'll hear from Ethan. Do you want to stand up here, Ethan?
Yeah, I'll stand up there.
And let me give you the microphones. Okay, well, I guess this is working now, so you tell us.
Okay, can you hear me? I regret the prosecutors, the DAs are no longer here. I would have liked to talk some comments to them as well. Oh, you're here. Good. Thank you. Thank you. One of them's here. Okay. So my name's Ethan Nadelmann. I've been involved in studying drug policy and working to end the war on drugs and promote drug policies grounded in science, compassion, health, and human rights for a very long period of time. One of the things, I used to be a professor. Before that, I had a security clearance at the State Department's Narcotics Bureau, interviewed drug enforcement agents around the world, wrote a couple of books about international drug enforcement, then taught at Princeton in the late 80s and became an activist at the beginnings of the war on drugs in the late 80s, and then started an organization that became known as the Drug Policy Alliance, which became the leading organization in the US and around the world advocating for reforms to drug policy. A lot of our work fell into three main areas. 1/3 of the work was ending marijuana prohibition, first with respect to medical, and then more broadly, reducing marijuana arrests, et cetera. The second major area was ending the role of the drug war in mass incarceration. And the last third of our work was advancing what are called harm reduction policies, public health and human rights policies to dealing with drug-related problems, from things like needle exchange, overdose prevention, honest drug education, teaching Americans about European sorts of approaches. So that was the major. I stopped doing that 6, 7 years ago. I'm now sort of playing the role of a movement elder. There was a podcast you might check out called Psychoactive. I hope you enjoy it, where I interview people across the wide range of drug subjects. Now, just quickly, if I could just get send you, how many of you are students? Just raise your hand. Not many students. How many of you are faculty? What are the rest of you doing here? How many of you ever used marijuana? Please raise your hand. How many of you never ever used marijuana? Raise your hand. Oh, wow, it's a surprising group here. Okay, and how many of you ever used MDMA or psychedelics? Raise your hand. Okay. And how many of you ever been to jail because of a drug charge? Okay. No? You can raise your hand. Okay. And how many of you have people in your families who have struggled with one form of drug addiction or another? Raise your hands. Okay, so we understand here that many of you, and that we all know that there are people who can use drugs responsibly and without problems, and that there are people who use drugs and it's the worst possible thing you can imagine. These things can have horrible consequences in themselves and their lives. To me, the whole question has been that drugs are here to stay, that there has essentially never been a drug-free society, there's never going to be a drug-free society, that the challenge is not how do we keep the drugs at bay, how do we build a moat between those drugs and our kids, between those drugs and our society. The question is, how do we accept the fact that drugs are here and that we have no choice but to learn how to live with them, to live with that fact so that they cause the least possible harm and in some cases the greatest possible benefits. That's the challenge. That's the human challenge. I have to say, in a conference that's progressives versus conservatives here, I've never really regarded myself as a progressive, even though I've been a major drug policy reform leader. I saw myself as kind of a radical centrist, asking the kind of common sense question, given these realities, how do we learn to live with this stuff? Now, as somebody whose political values were very much kind of centrist, I have to say, going back 40 years ago, here I'm a guy who was at college in the late 70s, started smoking marijuana, enjoyed it, wondering why people are getting busted for this stuff. I liked alcohol too, but I also saw people getting more violent and creating problems and wondered why is one legal, the other one not, right? As I got a little older, I experimented with psychedelics, I tried other drugs, some of them found beneficial, some I didn't want to touch. I had friends, some of whom got into trouble with drugs, others not. But what happened during the 1980s, I began studying this issue really in 1983, 40 years ago, before this was a kind of big front and center issue. But by the mid-80s, especially with the emergence of crack cocaine, we had the beginnings of a drug war that just escalated in something absolutely monstrous. Monstrous. I mean, when you look back at this history, and some of you are obviously far too young to remember this, but it was like McCarthyism on steroids. It was like a demonization, a scare. Marijuana, which had almost been getting decriminalized in the 70s, gets swept up to the drug war and linked with crack cocaine. I mean, enormous fears, all linked with the whole crime problems, international problems, you name it, right? I had people I knew who were working on Capitol Hill, and they talk about the committees where they were having hearings about drug sentences. And there was no evidence being presented. What will happen to drug use if we double the criminal penalties? No evidence. What will be the unintended consequences possibly if we double penalties or we do this or we add fines? Nobody was concerned. There was no science being brought to whether or not what this policy would be better than another one. None whatsoever. People sitting around the table were saying it was almost like playing poker with somebody else's chips. One person, this is, by the way, a bipartisan thing. Democrats would say, oh, I think we should raise the penalty to 5 years and $10,000. No, let's make it $10,000 and $20,000. No, let's make it 20 years and $100,000. No cost-benefit analysis of what was going to happen if you start spending billions and tens of billions of dollars, locking up huge numbers of people, empowering cops. No thought about what was going to happen to other types of crime. No thoughts to what were going to be the criminogenic aspects of enhancing penalties on drugs. And I'm looking at this and I'm going, this is madness. This is crazy. The more you study the science, the history, the economics, the more you realize that drug policy dealing with drugs should be going in the direction of decriminalization, public health, what were emerging as harm reduction approaches, but the public, the politicians, the media were all going the other way. All going the other way. The United States is not historically known as a mass incarcerator. You go back to 1970 and up to 1980, our rates of incarceration were more or less at the global average. In 1980, we had roughly 500,000 people behind bars, total, of whom about 50%, 50,000 were there, 10% on a drug charge of one sort or another. You get to the point of the late 90s, early 2000s, and we are surpassing 2 million people behind bars, right, total. So a quadrupling in the overall incarcerated population, right? And the number going up there on drug law violations is going from 50,000 to 500,000. We then began to peak out around roughly 2010, 12, 13 at 2.3 million, right? About 1.4 million in state prisons, to 200,000 in federal prisons, and others about 700,000 in local jails, right? And you see these numbers astronomical. Now, some of our conservative colleagues here will say, well, point out, nobody's going to prison for just simple drug possession. And true enough. But what they ignore, of course, is the fact that what you had in the federal prisons, you had 2/3 of the 100,000 people in federal prisons there on drug charges, mostly trafficking, being a courier, being some low-level schnook who was, smuggling drugs in because they were getting paid a few bucks to come from Mexico or Central America, whatever, that sort of thing. Very few of the major drug traffickers. You look in the state prisons, you had huge numbers there, not for possession, but for all sorts of oftentimes low-level sales offenses, drug addicts selling drugs, all this sort of thing. And what they don't point out is in local jails, an unknown percentage, but we know at least 20 and possibly 30% also being there for straight-out drug charges. What they don't count is the number of people who are getting locked up, because in state prison, you're not going there for just simple possession, especially on a first offense. But if you're one of the 4 or 5 million under parole or probation, and you're failing a drug test or getting picked up on a petty drug thing, you're going in there. It's not going to be listed as a drug offense. It's going to be listed under the shoplifting or the petty crime or the sex work crime that you were in there originally. They're not listing the people who are addicted to drugs and are having to raise a lot more money to support their drug habit than they would for their cigarette habit back then or their alcohol habit, because these drugs are illegal and they're engaged in sex work or other sorts of crime, and they're there. You look at the rising crime rates in the 1980s and 1990s. How much of that was about people involved in the drug business shooting one another, killing bystanders, killing all this sort of thing? A massive kind of criminogenic aspect to the war on drugs. In the 1980s into the 1990s, the war on drugs was the cutting edge of mass incarceration. When I was beginning to get really focused in the late 80s, early 90s, I was looking at the stats. I was in New York. Over 50% of new commitments into state prisons in New York and New Jersey were for a drug law violation. In D.C., even higher than that, right? You're looking at massive numbers. You look about the women behind bars, overwhelmingly drug charges, because they were less likely to be involved in violent crime, other sorts of things. Overwhelmingly the #1 charge of women getting there. We became, the number used to be 5%, we're 5% of the world's population, but 25% of the world's incarcerated population, dropped down to 4%, but 20%. We are still maybe not not number one. I think there's a couple of Caribbean countries which somehow they got, 5,000 people and a bigger number behind bars. But I mean, we're right up there at the top. Forever and ever, the Russians were number 2, chasing us, huffing and puffing, trying to keep up, but they could not beat us. We were number 1 in mass incarceration, and the drug war was driving that. Well, I'll tell you, when drug policy reform emerged in the 1990s, and I was proud to play a key role in all of this stuff, and just as the war on drugs had been the driving edge of mass incarceration in the 80s and 90s, drug policy reform became the driving edge of criminal justice reform beginning in the late 90s and into the aughts, right? When we look now that the prison populations, the overall incarcerated population has dropped from 2.3 million to about 1.9, I think that's been driven by the reduction in the number of people getting locked up on drug charges, right? I've never been much of a liberal. You want to put violent people behind bars? Go get them. People committing predatory crimes? Go get them, right? I was concerned at the ways in which the drug war was driving people to engage in predatory crimes to steal and support their habit. I was concerned about the ways in which the drug war was driving violent crime by causing people to shoot it out over businesses and disputes because they couldn't take their disputes to court. The only way was with crime and criminal violence and this sort of stuff. It was a monstrous process. Now, the fact of the matter is media, fears, politicians, our kids, race, it all plays into this thing, right? I also have to say, I've never regarded myself as a racial justice advocate. I don't. I'm a human rights advocate, grounded in science and health. That's what I'm about. I'm a human rights advocate. But when you look at the ways in which the war on drugs has disproportionately impacted and been directed at people of color, and especially blacks in this country, you cannot but help to realize that you're fighting for racial justice at the same time that you are fighting for human rights. When I was the first one, the draconian drug laws in New York, the Rockefeller drug laws, right? 94% of all the people locked up on Rockefeller drug charges in the 1990s were black or brown. No way was it possible that 94% of all the people involved in selling heroin and cocaine were black or brown. When I looked at the marijuana arrests, right? If you were to randomly stop 100 black kids, 100 brown kids, 100 white kids in any neighborhood in America, roughly the same percentage would have a little weed in their pocket. But in every town in America, the black kids and the brown kids were 2 to 10 times more likely to get busted than the white kids. That's just not fair. It's not fair. It reflects an element. You can say black people are 4 times more likely to be shooting one another, whatever it is, but it wasn't true when it came to drug possession. Yet the punishments were that much more dramatic. At the same time, there was a health consequence, right? We had HIV spreading through because injecting drug users were, sharing infected syringes. Countries like the UK, even under Margaret Thatcher, no less, the right-wing prime minister, the Netherlands, Australia, others, right away said, you know what, just goddamn common sense. Have clean needles, dirty needles, let them throw the dirty needles, do a needle exchange program, increase access to sterile syringes. Those countries kept their HIV rates among injecting drug users to under 5% of those countries. You go to a place like New Jersey, 50%. 50% of all the people injecting drugs were turning out to be HIV positive. Roughly 200,000 Americans died prematurely, not just injecting drug users, but their lovers and their kids, because America failed to embrace the common sense harm reduction policies, needle exchange and otherwise, that had become commonplace even in conservative European countries. That's how we felt, because the drug war was not just about incarceration. It was also about saying that the only permissible relationship between a human being and a drug is abstinence. No permissible connection. And if you are not able or willing to be abstinent, then you need to be punished. And we're doing that for your own good. Got it? And if you're going to die for your own good, too bad. You're not going to use those damn drugs. Treatment, oftentimes with nothing more than 12-step programs. Really, John? Okay. Let me do the Bertha method. I'll just keep going here. The fact of the matter is that I looked at Europe a lot in those days. Europe had serious problems in the 80s around drug-related street crime and AIDS, right? I mean, all throughout, right? And there was a problem. And the cops were doing the same thing as the Americans, chasing the junkies around all over the place, locking them up. They come out, locking them up, the whole thing, right? They kept trying things, right? But the fact of the matter is they began to get a handle on it. You saw this happen, for example, in the Netherlands first. It wasn't just their decriminalization of marijuana in '76. It was also about advancing these basic harm reduction different policies. It was about trying to push drug users off the streets. It was about saying, let's not just make methadone available, not just through highly regulated clinics, but make it more widely available. Let's use whatever treatment works. Let's use the principles of harm reduction, except that some people are going to keep using drugs, and let's figure out a way to keep them alive and safe and minimizing the harm they do to other people till the point they might be willing to stop. It was Switzerland 30 years ago saying, if methadone doesn't work and you can't get it through drug-free and 12-step programs, well, you know what? We're going to give you pharmaceutical heroin in clinics. Can't take it home? And those programs turned out to be successful. And they were replicated not just all throughout Switzerland, but into Germany and Netherlands and Denmark, and then into Australia, and not Australia, into Canada, and now you see them in Denmark as well. Proving successfully that even getting people to come to a clinic who are addicted to heroin and getting them to switch to pharmaceutical heroin instead, right? That in fact, that could reduce HIV, overdose, it could reduce their involvement in criminality, it could help them stabilize their lives, some of them could actually get jobs, there was no negative consequences for the broader community, and the programs actually more than paid for themselves in terms of the reduction of criminal justice and public care costs. That was harm reduction in action. Part of my ambition in building the Drug Policy Alliance and in helping to build a broader political movement to end the war on drugs was in saying there are better ways of dealing with the reality of drugs in our society. So now on the marijuana piece, hey, medical marijuana, some local activists drafted that thing in '96 here, came to me. It was my first time getting more political after academia. I was able to raise the money, oversee the campaign that legalized medical marijuana in California. Then the next 4 years to take it to Alaska, Oregon, Washington, Colorado, Nevada, Maine, do the same thing there. Then state legislatures began to follow suit. Why did we do it? Two reasons. One, because we believe that people who use marijuana legitimately for medical purposes, that they had a moral right to be first in the line to be decriminalized. Secondly, because we hoped and believed, and were ultimately proven right, that it would transform the broader public understanding around marijuana. Not that marijuana is safe. We know marijuana can be, I know people who've been totally fucked up for marijuana. Marijuana can be a powerful and dangerous drug for some people. But we also know there's never been an overdose fatality in the history of marijuana. We also know that when you look at any national commission that's ever emerged, and look at from the UK to France to the US to Canada, they typically conclude that marijuana is perhaps the least dangerous psychoactive substance commonly used in that society. Doesn't mean it's safe for everybody. Doesn't mean it might be associated with other sorts of things. Doesn't mean we shouldn't be associated or worried, as Bertha was suggesting, about the higher potency marijuana is there right now. But when you look at the net balance, it's to say that, you know what? Here's choice A. 700,000, half of all the drug arrests in America, 750,000 have 1.5 million people getting busted for marijuana, 90% simply for possession. Tens of millions of people with a marijuana arrest record. Millions of people being drug tested for marijuana and fired, not because they were high in the job, but because maybe they got high on a Friday night and they're testing positive on a Monday, right? All of the women being stripped of their kids when they're giving birth, especially poor and dark-skinned women, and telling you use marijuana, we're taking your baby, putting in child services. All of the horrific consequences that happen. So now when I see the marijuana thing booming and blossoming and all this sort of stuff, I am worried when I see daily use of marijuana by adolescents increasing. I am worried about that. I am worried about some of the other things that are going on. But I know all things considered, big picture, we're a hell of a lot better trying to figure out the right ways to legally regulate marijuana with all the troubles it takes, especially in places like California, New York, what have you, than we are going back to that bad old system. I know that when it comes to psychedelics, and I was delighted to hear Paul Larkin from Harvard talk about psychedelics, we have a psychedelic renaissance now, God bless it. What Oregon did by legalizing, the health elements of this thing, Colorado now decriminalizing possession and the things, it's a renaissance. A lot of people are going to benefit from this thing. Does it need to be regulated? Yes, but is there also the fact that millions and millions and millions and millions of Americans, including yours truly, have benefited from using marijuana without any therapeutic, psychedelic, whatever, and I don't want a regulated, government-sanctioned, therapist telling me? Time up. So let me just conclude by saying that now as we're dealing with this horrific issue of the opioid overdose and fentanyl, and the drug presenting new challenges, the fact is the matter, we know law enforcement is not the answer. We know the prosecution, we know interdiction, we know that's billions of dollars down the drain. It requires innovative approaches, ones that try to minimize as much as possible the role of the criminal justice system in drug policy, while we seek to apply basic values of human rights, science, evidence, and compassion to dealing with this issue. Thank you, John.
Thank you, Ethan. First, I'd like some guidance from the organizers. Can I go to a little bit after 4? I don't want to rob from our last substantive panel. And then we'll come back to the panel.
Hello. Great panel, very interesting. So I was a public defender for a long time, and in some ways that's the best advertisement against drug use, because you meet a lot of people whose lives have been destroyed by drugs like methamphetamine and fentanyl and so forth. But it seems like our main intervention is to cycle them in and out of jail, which is in many ways the worst possible intervention. I've had clients who died of drug overdoses after getting released from jail because their body was no longer, used to the amount of dosage they were taking. Yeah. I've also had clients who've gotten addicted to drugs in custody because there's a wide availability there. So I guess if you could evaluate the use of jail and cycling people in and out of jail through probation and so forth as a public health intervention, and if it's not a very good one, which I think it's probably the worst possible, is there a better approach?
Yeah.
Thank you. Let's hear from our panelists. You want to start?
I would like to answer the mother, because that's obviously a very prominent issue in my life in terms of raising children. First of all, I'd like to preface it by saying that Harvard X, which is run out of the provost's office, has agreed to me and a team of about 14 people developing a 10-hour course for parents on how to handle drugs with their children, especially their teens. So stay tuned, that's coming to help. The second issue I'd like to focus on, and this is a very important one, is making the distinction between herbal and pharmaceutical. There are three factors that you should know as a parent. Number one is that the brains of all animals, including fruit flies, Drosophila melanogaster, all of them respond to drugs in the same way, whether they're herbal or non-herbal. You can get, cocaine is clearly a direct extract from the coca erythroxylin plant. So that there are intrinsic neural circuits and neurotransmitters that respond to drugs in a certain way. And there is still, we know a lot about the genetics of drug use and who gets tolerant and who is easier to recover and all that, but the genetics are not on an individual basis, so there are no predictions. So we cannot foretell whether or not a person will or will not become addicted. That's just point number one. Point number two is the distinction between herbal and pharmaceutical is a very interesting one. In our plant world, there are over 300,000 plants that exist on planet Earth, 300,000 species, of which only about 300, and give or take 100 or so, are edible. And the rest are toxins. And the reason they're toxins is because they interfere with the function of anything that is going to eat them. Because plants don't have fingers, they don't have teeth, they don't have legs, they can't run, and their main protection is poisons. Now, it turns out that marijuana, cocaine, and nicotine that's found in plants, all of these interfere with the nervous system of insects that attack them. So making the distinction between a natural plant and a pharmaceutical, from my perspective, is just absolutely not scientifically based. Psilocybin, which comes from the psilocybin mushrooms, ibogaine, I can go through all the pharmacopoeia in terms of hallucinogens as well as other plant-derived, and tell you that given a certain amount, a certain dose, in conjunction with the genetic platform of the individual using them and their individual and environmental circumstances, can lead to tremendous problems.
Yeah. Let me make just two quick
I want to make sure we get one more comment in, so let's go down the line, but pretty quickly.
Two quick points. I agree with Bertha about it really isn't a good difference between synthetic and natural. Just for your information, when I had the drug talk with each of my three sons, I told them one of the problems is, yes, they can do you harm for the reasons Bertha mentioned. I said, but an even worse problem is they're too good for you. You take them, you can feel too good, and then it controls your life because you want to do nothing but get more of that good feeling, and that's a problem. And the other thing I would say is use photographs. Have you seen the photographs of what xylazine can do to people? It's an animal tranquilizer, and it causes these putrefying abscesses and necrotic tissue in limbs. And you tell people, you can get something from a friend, and you may think that you're getting, you know, something that'll keep you up all night to study for an exam, and it could have this in it. And this is what's going to happen.
That's the point that she's making. You're just supporting her point.
What? You know, I'm telling that show people what can go wrong.
Let me just say here, I mean, I think basically your instincts are right. And I should say, you know, we had to deal, obviously, what do you do with kids? I think our basic message to kids first was don't do drugs. And the second was don't do drugs. And then the third was, but if you're going to do them, there's some things I want you to know, because my bottom line as your parent who loves you to death ultimately isn't did you or didn't you, it's are you going to come home safely at the end of the night and grow up and make me healthy grandkids, right? I mean, that's the bottom line. And so, you know, we started a program. In fact, the pioneer of that program, Marshall Rosenbaum, sitting right here, we started something called the Safety First Program at Drug Policy Alliance, which has now moved to Stanford University. And it's basically the sex education model of drug education, which is you want to delay the onset as much as possible, but then you want to make sure they stay safe thereafter. So your instinct about plant versus pills or powders, I mean, the fact of the matter is, yes, there's some element of truth that is saying there are plants that can kill you. But by and large, marijuana is not, mushrooms are not, other plant stuff is not, plant versions of, you know, peyote, whatever, not going to, by and large, kill you, right? It's the pills and it's the powders where you don't know if it's got fentanyl in it, right? Those couple of kids who thought they were getting MDMA down in LA and landed up with, you know, fentanyl and were dead. People who thought they were just recreationally using a little cocaine and landed up dead. So the powders and the pills basically stay away from. And if you're ever thinking about doing it, make sure you know a handful of people who took from that same batch before and they were perfectly fine before you even contemplate playing with that sort of stuff. Then there's the basic things about, like, you know, we don't want you to drink in the morning. You shouldn't be waking and baking with weed. You know, you're going to be getting high on the weekend with your friend, and you think you can handle it, okay, but like not during school, you know, not during this, you know. I mean, if you're going to do psychedelics, you're not going to do it at a concert. You're going to do it with somebody you trust. You're not going to get high and, you know, having, you know, all this sort of stuff at some place with people you don't know. So it's just a lot. Don't get in the car with somebody who's high. It's the basic things. And call me if you're in a problem, and I promise you, I'm not going to beat up on you for calling me when you feel you got a problem. Like, you can talk to me, and I'm not going to clamp down on you. I want you to be safe. I want you to grow up safe. That's the bottom line.
Can we get in Professor Armour's comment, and then we'll come back for some closing thoughts from our panel?
Yeah, Leo, to you for a moment. You know, I teach criminal law. I'm teaching it this semester. One of the basic principles that we learn in causation law, I'm thinking about the Riverside DA who said, I'm prosecuting folks because they're like DUI, you know, right. People who cause death in DUI. One of the foundational principles we learn in causation is novus actus interveniens. We have a case in which somebody gives somebody a gun who's contemplating suicide. They shoot themselves with the gun. There's no causal connection. The law says, no, the causal chain was broken by their act of volition when they put the gun up to their own head. So these laws, you know, that's nothing like DUI. There's no, you know, novus actus interveniens issue in DUI at all. So that we've gotten to that point, you know, is curious to me. So I want to ask you about that. How have we been able to set aside that foundational principle in causation to get to this point in prosecuting these people? And then Ethan, real quickly, law enforcement action, law enforcement against prohibition. Yeah. That was it was originally LEAP, law enforcement against prohibition, who said, it's nuts what we're doing out here as law enforcement officers, as chiefs of police, captains, lieutenants. We realize this war on drug is counterproductive, self-defeating, generating reservoirs of resentment between us and the communities that we're policing without a tangible payoff, net benefit at the end. You know, it's like alcohol. Alcohol was bad. We put it in the Constitution to outlaw it because it was bad. It was causing a lot of domestic violence. It was causing a lot of harm. But the consequences of outlawing it were even worse than, you know, the alcohol itself. So why haven't we learned from prohibition and you know what happened there? So first to Leo and then to Nathan.
Thanks. And a last response from both of you, and any last thoughts.
Jody, I feel like you answered your own question, which is that the analogy between a DUI and prosecuting someone who is a dealer for
basically manufacturing a murder from an accident, those are not analogous, because if we're prosecuting the driver for DUI, we're not prosecuting the car manufacturer for DUI. And essentially that's what you're doing when you have a drug-induced homicide prosecution, aside from the fact that, in many cases, the dealers or the crime is distribution. There's not even a financial transaction that's required. It's simply sharing drugs between one person and another. And in that case, there's oftentimes not the knowledge that the drug contains fentanyl or not, or what concentration from a dealer. There's also basically an assumption of risk of doing an inherently dangerous activity from the person who's doing it. And so, it doesn't comport with the sort of traditional norms of criminal law. And the reason why is basically because of performative politics around this issue and saying, we're doing something about this. And what we're doing is we're holding people accountable for poisoning our communities. And that sounds really great when you put it on TV, people do press conferences, it plays really well to the constituency. Unfortunately, it does nothing to address the overdose problem. In fact, it makes it worse. In addition, looking at the thing that Chase had highlighted, using naloxone, which is an overdose antidote, as evidence of guilt is absolutely counterproductive. That is the definition of something that the criminal legal system does that is going at cross purposes to what the public health evidence states.
30 seconds.
Yeah, I said to that Riverside prosecutor, I said, if you were prosecuting people, the guys, whoever, if there was somebody selling what they knew to be fentanyl to some kids who they thought they were buying MDMA, I'm with you, because that is a form of fraud resulting in death. But in the absence of that kind of information, when people know what they're getting, or have the reason to believe they know what they're getting, all this sort of stuff to supplement this sort of thing, or to use as Leo's saying, naloxone, absolutely impermissible. As for the analogy to alcohol prohibition, it was my starting point, right? And in fact, a lot of the rhetoric we saw about drugs, like crack cocaine, the same rhetoric was used about alcohol. In the end, alcohol can be a remarkably dangerous and problematic drug for minority people who use it. But in the end, prohibition, did not work. I was talking earlier with, I think Ralph was going to be the next panel, and he's saying, well, so he was moved because he saw cirrhosis levels dropped during cirrhosis levels, the harms dropped in the first years of prohibition when everything came together. By the end of alcohol prohibition, at least as many people were dying, getting alcohol poisoning, cirrhosis before, but immediately had Al Capone, crime, violence, corruption, disrespect for the law, overflowing jails and prisons, all that stuff. Once again, up to today, it's just as futile in many respects. Doesn't mean the answer is to legalize all drugs the way we do alcohol, but it means to be moved toward that direction, to reduce as much as possible the role of the criminal law and criminal justice system in drug control, up to the point where we think going further might actually create more harm than good.
30 seconds from the right. Anyone?
My 30 seconds is, where does it all end? We have, with in silico now, artificial intelligence, we can make 70 million compounds that will target the hallucinogenic receptor, of which we have no clue what will come of it. We have more than 30 million people addicted to drugs currently. We have 2 million teenagers addicted to marijuana. Where does it end? At what point do we say that the criminal justice system has to step aside and let unfettered access to use, which enslaves people eventually, the ones who are vulnerable, certainly not everyone, not the casual user, but the people who are enslaved are going to be in deep, deep despair, and so are their families. Where does our tolerance to drugs end when we know that there are so many others coming down the line and we're engaged in a human experiment without informed consent?
And with that, I'm afraid this panel has to end. But please join me in thanking this terrific set of speakers.
We should have a 10-minute break and try to get back on schedule.